Hey guys, Dr. Brandon Crawford here. I'm the founder of the Austin Center for Developing Minds. We are located just north of Austin, Texas in Cedar Park. And what we do is we focus on developmental functional neurology. Hopefully you'll have a chance to catch my lecture because I'm going to be taking you through what that process looks like and why it's so important to focus on rehabbing the brain in the right way, at the right time, with the right frequency and oscillations and all this kind of stuff, right? So I'm very honored to be a part of this conference. This conference is very meaningful. I love all the people involved, and obviously the cause is fantastic. So thank you again, and I look forward to seeing you soon.
At Cook Children's, we know if we work together, we can keep each other healthy.
Wearing a mask keeps droplets from your nose and mouth trapped so you don't spread viruses to others.
Wear a mask when you're going to be around people outside of your immediate family.
Avoid large gatherings and wash your hands a lot.
These simple steps can limit the spread of viruses.
Let's all do our part to keep our community healthy.
Okay, so my name is Kristen Taylor. I'm a pediatric rehabilitation physician at Cook Children's Medical Center in Fort Worth, Texas. And I'm here today to talk about rehabilitation after brain injury and the long road to recovery that follows a brain injury, whether it be in a child or an adult. So today we're going to be talking about what is rehabilitation, what are the different levels of rehabilitation, when should we start talking about transitioning from one level to the next, and what are the long-term rehabilitation options that are out there. So first, what is rehabilitation? The definition is providing help for disabled persons or the removal or reduction of disability. As a rehabilitation physician, I often focus mostly on improving function, quality of life, and adapting and overcoming barriers to bring about success. And this is not just improving function and quality of life for the patient, but also improving function and quality of life for the family, who often has to take over all of these deficits that have resulted from the brain injury or illness. Family training is a crucial part of this rehabilitation process, both in how to take care of this child or this patient, but also in how to use the equipment that's been prescribed, how to ensure that we're causing no harm to the patient as we push them to succeed. So what are the levels of rehabilitation? My mind often divides rehabilitation into two specific phases. There's the acute phase of injury immediately following the either traumatic, ischemic, or infectious brain injury. And that can be anything from trauma from a car accident, a stroke, an ischemic event like a drowning or prolonged CPR, anything like that that is a new injury that was not there previously. And then in the acute phase, there are three levels of rehabilitation. The first level is acute inpatient rehabilitation, often abbreviated AIR or IRF, inpatient rehab facility. There's going to be a lot of acronyms, but I'm trying to describe them all for you so that you understand when other healthcare providers use these, you've heard them before and know what they mean. The second level is a skilled nursing facility or a SNF, and then the long-term hospital, the long-term acute care hospital, LTAC. So these three phases are following the acute injury, and I'll go into each of these different options as the next slides come about. And then there's the chronic phase of injury. So more than 3 to 6 months following an injury or from injuries occurring around the time of birth. And I include the injuries occurring around the time of birth in the chronic phase for a couple of reasons. The first, typically when you think about an injury occurring around the time of birth, it's a diagnosis of cerebral palsy, and it can take months to recognize that a child has cerebral palsy, that they have a deficit, or that one side is tighter or looser or weaker than the other side. But also the primary cause of cerebral palsy is prematurity. So these babies often spend several months in the NICU. And so By the time they get out of the NICU setting, it's often several months later, and so we're addressing rehabilitation goals months after the known injury. In the chronic phase, there are several types of therapies. ECI therapies, which are early childhood interventions, home health therapy, outpatient therapy, and then what parents like to call boot camp facilities all over the nation. So in the acute level of rehabilitation, the highest level of rehabilitation is acute inpatient rehab, again, IPR, or acute inpatient rehab, AIR, IRF, inpatient rehab facilities, all of these are the same thing. And to qualify for acute inpatient rehabilitation, the patient must be able to actively participate in up to 3 hours of therapy per day. And this is not 3 hours all at once where you go to the gym from 9 to 12. This is divided up into 30 or 60-minute blocks throughout the day, but each day they receive 180 minutes of therapy per day. And this is designated by insurance companies. The patient has to require at least 2 of 3 different types of the main therapies, PT, OT, and speech. And they're followed by their medical team daily. So these patients need ongoing either daily labs or monitoring of weight or caloric intake or testing to be done, like swallow studies. Each day, a medical team is having to make acute medical decisions to improve their stay and march them towards discharge home. The next level of rehabilitation in the acute care setting is skilled nursing facilities, or SNFs. And these patients typically receive 30 to 90 minutes of therapy most days per week. So 3 to 4 days per week, they're receiving some sort of therapy. And this is a great option for kids that aren't quite ready to commit to the 3 hours of therapy per day, but need some sort of therapy, but maybe cognitively aren't able to do a full 3 hours per day, 6 days per week, or are just ongoing medical treatments don't allow for 3 hours of therapy. This is commonly seen after an oncologic diagnosis with surgery, where the kiddo's actively undergoing chemotherapy, those sorts of things where there are other needs that are taking precedent, but they do need strengthening and conditioning. And then lastly, in the acute phase, there's the long-term acute care hospitals, which are LTACs. And this is where the focus is mostly on their overall medical needs, but they may receive intermittent therapies if they receive any therapy at all. Typically, when I hear of a kiddo going to an LTAC, the primary thing that they're focusing on is vent weaning. So trying to get them off of their ventilator during the day and hopefully off of it completely, but if they can't, or maybe they're just on like a supplemental oxygen during the day and a ventilator at night. And so a pulmonologist is rounding on them daily to make sure that their lab values are all normal, or these kids are on long-term IV antibiotics while awaiting bones to heal after a car accident, and the orthopedic surgeon is not allowing them to bear any weight on their legs. And so they need to go to a hospital, but aren't quite ready to start therapy because they can't do any sort of weight bearing or lifting, that sort of thing. So those are the acute levels of rehabilitation. What about in the chronic phase? So again, this is months after a brain injury has either been diagnosed or recognized. So ECI therapies, the early childhood intervention therapies, it's a state-funded therapy program for children under the age of 3 years old with any sort of developmental delay. So this can be motor delays with hands and walking being behind schedule. It can be speech delays, it can be feeding delays, it can be anything that puts a child at risk for either developmental delay or diagnosis of developmental delay. So this is 30 to 60 minutes of therapy per week, and this can be done via telemed, done via in-person learning, but the main focus of ECI therapies is always parent training, so teaching the parent how to do the therapy for their child, which is different than some of these other therapies like home health and outpatient, where it's more focused on teaching the kiddo how to do their own therapy. ECI is very much geared towards making the parent be the therapist long term. Kids enrolled in ECI therapies often transition on their 3rd birthday into PPCD or Head Start, which is the early school program that begins at the age of 3. So whenever a kid who's been in ECI turns 3 years old, the parents go to their local school district and enroll them in Head Start, and they begin a half day of school 5 days per week, where they'll receive therapy in the school setting. They'll have a teacher and a teacher's aide to help them learn early school, like pre-K, that sort of thing. And then therapy can be anywhere from 30 minutes per week to, some of my kids get PT 3 times a week for 45 minutes. Some kids get 15 minutes of therapy every 6 weeks. And a lot of that just depends on the school districts and how much money they have in their budgets to hire and maintain full-time therapists and how many kids are in the district that need those full-time therapists. So it's important when you have a kid that's turning 3 that's enrolling in PPCD or Head Start to have an ARD meeting and ask these questions. You know, what therapies do they qualify for? How frequently will they be receiving the therapy? How long are those therapy sessions? Because that information is helpful for me or for the pediatrician to know whether or not they should continue to receive additional therapy. You know, if it's 15 minutes once every 6 weeks, obviously I'm going to want to supplement that with additional therapies. But if they're receiving PT 3 times a week, 45 minutes, then I'm going to say maybe we should stop the home health or outpatient therapy because I don't want them to get burnt out when they're doing their therapy in school. So these questions are super important and very helpful to the medical team. And without parents bringing that information to us, there's no way for me to know. The next level of rehabilitation is home health therapies, which I'm sure most of you are very familiar with home health therapies. There are several companies all over the state that work with various insurance agencies. But you can receive PT, OT, and speech in the home setting. And typically this is 1 to 2 times per week for each modality. So I like to remind parents that if your child is receiving PT, OT, and speech 2 times a week, that is 6 appointments per week on top of all of your physician visits, on top of school, on top of full-time jobs, other children, sports activities. This is a huge time commitment. And these sessions are typically 45 minutes to an hour each. So this is several hours per week of therapy in the home setting. And this is, it's important to remember that these are therapists that come to your house, but they're coming into your house in a company vehicle that is very often like a Prius or a Honda Civic. And so what they're able to bring to your home is often very limited to what fits in the back of a car. So unless you have this equipment at home already, like a gait trainer or something like that. But it's important to think about what your goals are for each modality of therapy, PT, OT, and speech, because if in your mind you're thinking about like robotics and virtual reality, those sorts of things, then home health may not be the best location for your child to receive physical therapy because that's not going to fit in the back of the therapist's vehicle. So they may best be served in outpatient therapy, which is where you go to therapy in a clinic or gym setting. And this is typically done 1 to 3 times per week for each modality. I know most parents prefer to have therapy 2 to 3 times per week, but unfortunately, the frequency of your outpatient therapy is often dictated by insurance companies. Some insurance policies have specific numbers of visits per year that they're willing to pay. And so it's important to know the details of your insurance policy, because if your insurance policy only allows 20 visits per year and you're going to therapy 3 times per week, what are you going to do on the 3rd month of the year when you are out of benefits? So these are things to think about. But if PT specifically, in your mind, your goal is gait training and you need a treadmill with body weight support or robotics or virtual reality, then clearly you should request outpatient therapy for PT specifically. And it's completely possible to go to PT as an outpatient and do OT and speech in the home setting, or PT and OT in home health with speech in the outpatient setting. That's pretty common in kiddos who are getting feeding therapy with vital stimulation. It can be quite difficult to find a home health company in your area that accepts your insurance, that has a home therapist available who is trained in vital stimulation. It's like finding the unicorn. So it's common for a lot of my kids to be getting 2 modalities of therapy in one setting and then the last modality in another setting. You just need to be very specific when you're talking to your healthcare provider about what therapy you want in what location, because all of these things are billed differently to your insurance company. And so if I put in an order for outpatient therapy for PT, OT, and speech, and it gets approved by your insurance, but you wanted OT and speech to be done at home, now we have to cancel that order, which has to go through insurance, and then you have to reorder home health, which has to be approved by insurance. And so you have these lags in therapy, which is never anybody's goal. It's not the parent's goal. It's not the physician's goal. And parents will often see kind of a decline in their overall functional status with these lags. So being as specific as possible with what your goals are and where these therapies should be taking place when you're talking to your physicians about ordering this stuff. Last but not least, in the chronic level of rehabilitation is the boot camps. And so this is very much a kind of new and up and coming / specialized type of therapy, where the Napa Center, which is opening in Austin in October of 2020, our Children's House in Dallas, and then Teletón USA in San Antonio. I'm sure there are others throughout the state, and there are definitely others throughout the nation that will bring children in for day rehab programs, meaning they come in 5 days a week for 3 or 4 weeks, and they're in the gym most hours of the day. So 4 to 6 hours per day doing therapies. It's often done over summer or Christmas when kids are out of school and not missing other activities, or when parents have the time to take off and go stay at Austin, Dallas, San Antonio, or wherever for these longer term therapy options. The caveat to these programs is that Medicaid will very often not pay for these types of programs. And some major insurance companies will do day rehab programs, but most of them will not. And so a lot of times these things end up being cash pay, unless you have a GoFundMe or a church family who's willing to sponsor you to go to these centers. It can be thousands of dollars for a brief time of rehab. So when should we be transitioning into levels of care? When should we be having these conversations? So I like to show this graph to patients and their families to help them understand the plateau effect. So at the very beginning, following a diagnosis of a brain injury, whether it be a new onset brain injury or a birth-related injury, we have this phase where we're not really achieving any goals. We're not really making any functional progress, and that's because we're too busy saving your life, making sure your lungs are healthy, making sure your other organs are healthy, giving your brain a time to recover and heal. Typically, it's whether you're in the NICU or in the hospital, we just have other priorities at that time. But once we have medical stability, we see this huge upshoot in the level of improvement, and that's typically because of therapy. So if your child is able to participate in 3 hours of therapy per day, then that's when you should be advocating for your child to transition into inpatient rehabilitation, where they're receiving 18 hours of therapy per week. That's 3 hours of therapy, 6 days per week. That's the highest level of rehabilitation that your child can receive following an injury per insurance standards. And then you kind of notice that as time goes on, we tend to plateau. And this plateau can be one of two things. Typically, it's that we are physically reaching a barrier for the time being, that this is as much as we can possibly accomplish at this time with the level of injury that we've sustained. But the other major thing is emotional burnout. So these kids and the families have been in the hospital for weeks, if not months. And so they're tired of nurses and doctors. They're tired of the needles. They're tired of being woken up in the middle of the night for vital signs. They are tired of the same gym every day. They miss their family. They miss their dog. They miss their siblings. They just miss life outside of the hospital. And so emotionally, they start to burn out and they don't participate as well in therapies, which I'm sure that all of us can relate when we think about like our diet and exercise plans. When we stop buying into our goals, we stop making progress. And it's completely reasonable and expected to say, we need to take a step back. We need to slow it down. I just want to go home and spend some time with my siblings. particularly around the holidays or summertime, because everyone just wants to go out and have fun. So it's completely okay for a patient or a family member to say, I think we're done here, and I'd like to talk about transitioning to the next level of care for our quality of life and kind of our mental sanity. And that's completely understandable, reasonable. Everyone hits their wall, and that's okay. So transitioning from home health versus outpatient, I like to just bring this up because, like I said before, it is a huge burden to a family, whether you pick home health or outpatient. And these are questions that your healthcare provider should be asking you when you're talking about picking either home health or outpatient. Do you have transportation? Can you even get this child to a gym to go to PT, particularly if the child is a wheelchair user? Do you have a van that can transport that wheelchair to and from their clinic visits, to and from the gym? What about other children? Do you have 3 other kids who play soccer and are in Girl Scouts? Do mom and dad both work? You guys have school schedules that you're trying to fit within? Because most outpatient gyms, the last available appointment is around 4 or 5 p.m. So you have to take into mind, if you have to leave work at 2:30 to get to school by 3, to pick them up, to get them to their 4 o'clock therapy, like, this is a lot of scheduling. Do you have family that lives nearby that can offer support, that is able to lift your child? I know a lot of people are like, oh, my mom and dad or grandma and grandpa are able, but if they're not able to lift the child in and out of the vehicle, then that's another barrier. And then, like I said before, the limits of home health therapy. So if you're talking about gait training and wanting a treadmill to be part of your goal, then clearly the home health setting is not going to work out very well for you. And so making specific requests that your main focus is gait training and you envision either robotics or a treadmill, so that we know to order outpatient therapy for you. And then particularly in my brain injured kiddos, I worry a lot about sensory overload when I send them to the outpatient setting. So in my kids that are easily overstimulated, easily distracted, become self-harming in an overloaded situation, the kids that hit themselves or bite their fingers when they get sensory overloaded, do I really want to send them to an outpatient gym where there's several other kids that may be laughing loudly, crying loudly? It's just typically bigger rooms with loud equipment and loud kids. And so these are things to consider when you're picking a level of care. So we get this question a lot when we're discharging patients from inpatient rehab to home, whether it be home with outpatient therapy or home with home health therapy. What happens if we get home and I'm not satisfied and I want a higher level of care? What happens if I want to consider boot camp? What happens if we're at home health and I just don't feel like we're accomplishing things, and so I want to go to a gym? So this is definitely possible. It often just takes extra time and coordination, both on the family's part, but also on the healthcare team part. So for example, if I have a kid that gets discharged from inpatient rehab or discharged from the hospital, and the parents call and say, we're just not meeting any goals, and I really think we need more intensive therapy, I often will bring that child and family into my clinic for a 90-minute visit where I have a PT, OT, and speech in clinic with me. All of us will write up evaluations justifying why they need increased levels of rehabilitation and therapy. And we submit that to insurance, arguing our case for either increased frequency of visits or bringing them back into the hospital for a planned admission to the rehab unit to focus on specific goals. And this obviously comes with its own headaches because now we have put in all this work, and ultimately at the end of the day, the insurance company can say, we don't like these goals, it's denied. So that can be very frustrating, but it's up to the team to come up with very specific goals of telling the insurance company, if you will allow me to bring this child into the hospital for 3 weeks, my goals will be that they'll be able to have improved balance, have improved coordination, have better endurance, have less pain, be on less medicines, those sorts of things that will ultimately, to the insurance company, look like a prolonged savings of money because we're using less medicine and less risk of falls, less risk of infections, those sorts of things. So timing of intensive therapies with school and holiday schedules. This is a conversation that I like to have with my kids who have been, they were brain injured several years ago, and these parents and families have been pushing for 365-day per year therapies. And you can see it in their faces that they're all just completely burnt out and their entire lives revolve around when the next therapy visit is. So I like to tell parents and families that it's okay to take breaks. It's okay to say, you know what, we're not going to do PT, OT, and speech over the summer. We're going to start horseback riding or swim lessons or do some summer camps. So I tend to, this is particularly true in my families that have multiple other children, because it's important to kind of pay attention to the quality of life and emotional well-being of the other kids. So I often tell parents to pick aggressive therapies during the school year. And when I say this, I mean you're going to pick like PT and speech in the fall, and then OT and feeding therapy in the spring. And then we take summertime off to do horseback riding and summer camps. And then over Christmas break, maybe we do a boot camp or a different camp, different activities camp, or we just take it easy and don't have any appointments at all, which is totally reasonable because you have enough things to do with visiting your parents' house, your in-laws' house. The kids have plans. There's musical events and there's things going on. And I understand that life goes on and your life shouldn't revolve completely around therapy. So I show this graph of kind of highs and lows because ultimately at the end of the day, when you're 5-10 years out from a brain injury, you kind of want to just keep the status quo. You want to, if they're able to walk, you want to keep them walking. The goal is not to run a marathon. If they're not able to walk, but they're smiling and socially interactive and happy, then the ultimate goal is to keep them smiling, interactive, and happy. And whether they're smiling, interacting, and happy on the back of a horse or in a gym with PT, that's completely up to you as a family. And I have no judgment and no negative thoughts about any family that says we take off every holiday schedule, we take off every summer because we go on vacation or we have a pool in our backyard and that's more fun for us. I completely understand and support you. So long-term rehab options. There are several facilities. These facilities here, Pate Rehab, Troutman Smith, and my Royal Palace are the ones that are kind of located immediately around the DFW area, so the ones I'm more familiar with. But these are facilities where any child that has increased medical needs can go live. So if you as a family are facing burnout, if you as a family are needing respite, then there are facilities that will offer living options for children that have medical needs, particularly brain injuries, and they will do all of the medical care, all of the daily care, the child care, all of that on your behalf so that you can take a break, or so that you can, if you, heaven forbid, have breast cancer or something like that and need to take your own health into your own hands, there are other places that can offer support and assistance to you and your family so that they're adequately cared for in the interim. So again, you should know that these places exist. You should know that there's no harm in asking your healthcare providers about these places if they've heard of them or have had other patients that have gone to these places. And when they come into our clinics, do they look well cared for? Do they look happy? What activities do they have? And of course, if you are really interested in looking at these places, you should schedule a tour, go visit, talk to other families that have children there, and ask about their experiences so that you're making an educated guess about what the next step will look like. The wild world of insurance, which I'm sure everyone just rolled their eyes. Same here. So insurance often dictates the length of treatment in each level of care. What that means in the inpatient rehab setting, we as a hospital system are required to submit weekly progress reports. And this is where each week your PT, OT, and speech therapist have to make a goal that your child will achieve in the following 7 days. And next week when we submit that paperwork, if we show that you have met 0 of those goals, your insurance company will come back to us and say, they're not meeting their goals, discharge them tomorrow. And this happens all the time. It's very frustrating because often when they say discharge tomorrow, you're not ready medically to be discharged tomorrow. And so it's this evil game that they play where they've stopped paying for your visits or your therapy, but we keep you because you're not medically stable. And that can be very tricky in terms of billing for parents. Again, like I said earlier, outpatient therapy, every insurance plan is different, but several insurance companies limit the number of visits per year. And there is no caveat to you've had a subsequent stroke or you've had surgery. You've hit your visits and that's it. Your healthcare providers can do a peer-to-peer to try to fight on your behalf, but ultimately at the end of the day, it is dependent on the person on the other side of that phone and what mood they're in for that day. It's very frustrating sometimes. And then in home health therapy, my biggest limitation that I see as a healthcare provider is finding a home health therapy company in your area, particularly if you don't live in a large city. But finding a provider in your area that accepts your insurance, and then even if they do accept your insurance, do they even have a therapist available? So this is really frustrating for my patients and their families when they found a company that has PT and speech, but not OT. So then I have to keep looking for a home health OT company that accepts your insurance and has someone available. And then inevitably a therapist goes out on maternity leave or that therapist quit and now works for this other company. And so you get these lags in care because even if you call me and say, our home health OT switched to Green Apple. Okay, well now I have to send a new order to Green Apple to your insurance company requesting OT, which has to get approved and verified. And then you have to go under an evaluation, and then they have up to 4 weeks to approve treatment. So this can lead to a lot of lag times, which is very frustrating for everyone involved. So there are definitely limitations that are put in place by insurance companies every day, and it's very frustrating and it changes from day to day. And then, like I said, when I was talking about acute inpatient rehab, the insurance companies will focus on very specific goals to approve therapy and monitor progress. So while in inpatient rehab, we are responsible for sending weekly progress reports. In home health, it's often like every 8 weeks, we have to send a progress report showing what goals you've achieved and what our next goals are going to be to justify the following 8 weeks. So, and most insurance companies say that goals cannot be a maintenance of function or maintenance of range of motion. They want specific goals like they'll be able to sit up on their own for 60 seconds, or they'll be able to take 4 steps unassisted, or their diet will be upgraded from puree to soft solids. So everyone has to come up with very specific goals to justify the next month or 2 months of services. And then if you do not achieve those goals, you will be discharged from therapy for failure to progress. And lastly, so transitioning into adulthood, this is always a very scary topic for parents and children. So with private insurance and Medicaid, the therapy frequency is significantly reduced or stopped, and orthotics are typically not covered. And I bring this up because typically when I'm talking to my kids, I see kids to the age of 21. And around 18 or 19 years old, I try to encourage parents, even if AFOs and hand splints are fitting fine and they look really good, I encourage them to get another set because when they turn 21, orthotics are no longer covered by Medicaid. So it'll become a cash option only. And so it's always best to have 2 sets of orthotics than 0 sets of orthotics. So that's just something to remember for those of you that maybe your primary care doctor or somebody else is managing your orthotics. Around 18-ish, start asking for everything that you can possibly get as a backup. But with Medicaid waiver programs, therapy often can continue. Orthotics are often continued to be covered. Wheelchairs are typically approved. So I encourage those parents, particularly of younger children, to get onto the Medicaid waiver wait list through like NDCP or class, HCS, these sorts of things. And if you don't know what these things are, definitely look into them on the Texas websites, because these things they have very long wait lists, up to like 15 years of a wait list, but they make transition care so much easier when your child still needs therapy, still needs orthotics, still needs home health nursing, still needs specialized transportation. So this is really important to enroll early, like as I start talking to parents about it in the NICUs, because I know that if these programs have a 15-year wait list, that even if you're like, well, I don't think I'll really need it by then, just put your name on the wait list. That way, 15 years from now, when you get a phone call saying that their name has come up, you can say, you know what, I was right, I don't need it. No, thank you. But if you are like, oh, thank God, then you can put your child on that Medicaid waiver program and know that they'll continue to receive the level of services that they were used to as a 10-year-old or a 15-year-old. So thank you in advance for your time. This is me. Again, if you have any questions or need anything, my Cook email address is right there. My website is there. You can send me messages through our patient portal. But I encourage you guys to find a provider that you can trust near your hometown. There's not very many peds rehab doctors in the nation. There's about 320 of us nationwide, and we tend to cluster together. So I'm the only one in Fort Worth, but there are 6 in Dallas, 5 or 6 in Houston, 2 in San Antonio, and 1 in Austin. So look for specialized rehabilitation physicians. And then if you don't have one available, know that most of us are doing telemed visits. And I have an Oklahoma medical license. I'm seeing families in East Texas, West Texas, everywhere via telemed, and trying to connect these children to the services that they need and ensuring that they have the rehabilitation levels that are most appropriate for them at that time. If you guys have any questions, I'm happy to answer them. Otherwise, thank you so much.